Okay. Thanks for the wonderful talks. And just as the previous years, we have wonderful gathering and some fantastic talks. And starting this session, I'm going to taking over from Dr. Shah, and he's going to have some rest. And I'm here for your service and try to figure out. And we have a few more sessions today. And the next session would be the challenge of foot and ankle care in rural and underserved communities. This is Alan Yin. I'm from Sioux Falls, South Dakota, and the moderator for the next session is Dr. Kulkarni and his group. All right, please, the floor is yours.
Hello, good evening. Good evening to all my friends in India, and good morning to the US. We have a bunch of very diverse topics today, and I would like to start with Dr. Girish Motwani. He is a leading foot and ankle surgeon and works in Nagpur. He is the director of Suyog Hospital, and he has a lot of publication in index journals and a major contribution in organization of the conferences here in India. So over to you, Dr. Girish.
Thank you, Dr. Madhura. Thank you for having me this global platform. I'm sure that this will be the great learning for everyone. And thanks to Dr. Selene Parekh for initiating such a great platform for the transfer of knowledge across the globe. So my job in next 10 minutes is to talk about. Can you see my screen?
Yes.
Okay. So my job about as Dr. Madhura has already given the brief idea that these are some untouched topic, but we need to talk about what is the situation we are facing and how we are having the foot and ankle situation as a growing specialty in our country. So my job in next 10 minutes will be to talk about the access to the advanced foot and ankle care in rural and underserved communities. And my introduction is already given by Dr. Madhura, so I'm directly going to my talk. So currently I am belonging to a part of India which is called Central India, which contains 5 states and near about 120 million population. So we have all these specialties in shoulder, hip, spine, pediatric orthopedics, but somewhere we are lacking in a foot and ankle healthcare. And this is particularly important when you are dealing with some activities when you're dealing with some problem which affects your lower limb health and that affects
Dr.
your
Girish,
daily function. Sorry.
your screen, are you sharing your slides because we cannot see the slides?
No, I'm not
Okay,
standing here.
okay,
Yeah.
okay.
And it affects the mobility of a patient, which is very important. Can you see now the moving slides?
No,
My slide is moving now.
no, we are not seeing the moving slides.
We're seeing your browser right now.
Can you see now?
Not really.
You probably will need to stop sharing and try resharing and make sure to just double check what you're sharing when you're going in.
All right. So I'll share again.
Yeah.
Yeah. Can you see this?
Yes.
And is it moving now?
It's not moving, but we can see the first slide.
Okay.
We can see the third slide.
You're seeing the third slide?
Yes.
Okay, that means it is moving.
Okay.
Well, it's not, we don't see the presentation mode, so you may need to exit out of that and just do it from the normal slide view.
Okay.
We can see your mouse moving, so that would have worked well. So we can go that route.
Can you see now?
No, the presentation mode is not appearing for us.
Yes, it moved.
It moved?
This
Yes.
time it did after you came out of the presentation mode.
Okay.
The presentation mode is just not going to work, unfortunately.
Can you see the moving now? Moving slides?
So you're on the fourth slide.
Yeah.
Yeah.
So should I go ahead?
Yes, please.
Okay, so current situation of foot and ankle, as we said in the India, particularly in the central India, is you can see the high diabetic foot ulcers, because diabetic wise we are the second most highest capital in the world. Lack of awareness is still there, so there is a high risk of amputation even if you go in some tribal and the rural areas. It affects the severe impact, but particularly when you are dealing with the amputation, that affects the quality of a life. And it is not uncommon to have the ankle fracture malunion, neglected deformities, and the delayed union. The problem why it is happening is, there are the challenges is because of a paucity of a surgeons. Just one podiatrist or a foot and ankle orthopedics surgeon per 2 million population. This is really mismatch. Geographic barrier. People have to travel for at least many kilometers, 100 kilometers, to get this specialized care because the centers are limited. Barefoot walking increases the risk of infection. I'm sure the other speakers will talk about it. And of course, the inadequate public health investment may be the problem of having a paucity of foot and ankle care. Can you see the moving slides now?
No, you have to click on the fifth slide, I think.
Okay.
Yeah.
The presentation view is not going to work, unfortunately. You're going to need to just go through the normal slide.
Normal mode. Okay. So yeah. So what are the solution? The solution is you need to go to the rural areas, to the tribal areas, to create the various medical camps, to create the mobile units, to connect to the rural population directly. If you are if we are really looking for the care of subspecialty in the rural areas, and telemedicine it play a very important platform, because the cost effective care, the financial and the geographic barriers are still there in the population. So what actually works to create the access of any advanced foot and ankle care for the rural population is very important, is training the local people, or training the local nurse, or training the local doctors, or training the general orthopedic surgeons working in the rural areas. This is the best way of getting the access to the advanced foot and ankle care in India at present. Because as you can see in the slides, there are various programs which we have conducted throughout India with the help of Indian Foot and Ankle Society, just to train the young orthopedic surgeons so that they can learn the foot and ankle strategies, the wound management, and the techniques. And we have done a many international work also, like Steps to Walk in the India, or the Indian Foot and Ankle Society annual conferences, where we bring the people from all over the globe to teach those young orthopedic surgeons or the trauma surgeons to create more awareness about foot and ankle science and the foot and ankle strategies and the way of managing the foot and ankle problems. And it works definitely. When there are many success stories that after education, lot of learning programs, now you can see that the people have started knowing. Now this is a patient. Look at the feet. He was actually having a club foot deformity since birth, and he was not having the access to the foot and ankle care for many years. And 13 years he walked with the disability of a foot. And you can see that the one foot is well corrected and the other foot is still is our next program. We are going to correct his leg, and he is really enjoying a quality of life and a miracle in the foot and ankle care. Patient impacts, definitely there are many studies that now with the help of advancement or the access to the foot and ankle care, the ulcer healing rates are better. It's a government directory which is giving us the percentage that there are many amputation which has been prevented in the rural areas. Near about 1,500 tribal children, they got a treatment in 2021 to 23 about the club foot, and the various fracture management has reduced the amputation rate by 22%. Now look at example here, how the people they reach to the advanced foot and ankle care through a Google. So he is a 50-year-old male policeman. He belonged to the rural place from the Chhattisgarh state, which is one of the part of the central India which I look for. He has a pylon fracture which was malunited, so he presented with a stage 4 arthritis, malunited pylon fracture, and he was in pain for 8 years in spite of a policeman duty where you need to work, you need to run, you need to go for some high strenuous activities. This guy has beared the pain for 8 years. Now when in the Google, like in the periphery, the tribal areas, they came to know that there is a subspecialty which is called foot and ankle, and just from typing a foot and ankle orthopedic doctor in India, he got some 10 to 12 names, and then he has started contacting various surgeons. This patient, after many years, after 8 years, he finally landed with the ankle replacement, which was the miracle for his life. And this guy is really enjoying. And finally, after many years, he got a painless ankle. So this is a problem. Access to the foot and ankle, but it is possible with the telemedicine, it is possible with the education. Now, this is a 45-year-old poor farmer. He had a road traffic accident 3 weeks back, and he was just treated with the slab. This patient was referred to me by the young orthopedic surgeon who was trained by me 3 years back in some live operative workshop. Look at a way of access to the subspecialty. Now, this patient was just treated with the simple cast, and he said that uh, 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 there is just a minor problem in the TMT joints, and it may be okay with the slab. And if you see the CT scan, there are various problems inside the midfoot. You can see the first, second, third tarsometatarsal joints are completely subluxated, which has been taken care by our advanced foot and ankle care using the two incision techniques, using the various reduction methods, low profile implants. And this finally, this patient, he landed with the success story. The technique of the reduction in the Lisfranc as well as the unavailability of the implant in the rural areas, they are the challenging things still today. Few of the orthopedic surgeon in the rural India, they are aware that flat foot is corrected. So if you talk about the progressive collapsing foot deformity in their local talks, local program, they feel that it's a rare problem. But look at the example here. She is a 50-year-old female. She has a pain since 12 years. She has a progressive collapsing foot deformity, which has treated with minimal invasive surgery and an advanced deltoid reconstruction uh, uh, of the deltoid spring complex and a tibialis posterior tendon repair by various methods as we do nowadays. But this is not possible to see this kind of surgery as you enter in the rural and the tribal part. But awareness by creating education program or by the telemedicine or going to their places by conducting various camps has really made a difference, and this has created a access. Indian Foot and Ankle Society young orthopedic training courses, they were conducted for last 3 years. Dr. Madhura has also conducted one of the course, and the similar courses has been conducted all over the India just to create a awareness, and that increases the access. Look at the same patient. She had undergone a very successful flat foot surgery, and she's really enjoying walking with a arched foot and a painless foot. This is possible. This patient was in pain for 12 years. This is possible when you actually create awareness and when you actually create educational programs. So there is a target of creating 500 new specialists by 2030, as our Indian Foot and Ankle Society are getting more and more members. As of now, we need to advocate for the dedicated funding scheme also, which is important part of the NGO and the government. And definitely we need to ensure that the quality of foot and ankle care, they should reach to the district and measure the outcome with the standardized metric all around the population. Thank you so much.
Thank you, Dr. Girish. I will move to the next speaker, that is Dr. Amit Burande. Dr. Amit is a forefront personality in the salvage and treatment of diabetic foot. He works in Kolhapur and he has done many fellowships and he is continuing his research in the field of diabetics. And this helps him treat as many patients as possible in his hospital. So, welcome, Dr. Amit. Let's start with your presentation.
Audible? Is my screen seen?
Yes.
Okay. So when we talk about the urban and rural areas, these are the two typical pictures about the habitat and the work style. And these are the two typical pictures, at least in India, where we see the healthcare in a rural area on the left side and the high-end surgeries and advanced treatment going in the urban areas. And with this number of the very reputed medical colleges, there are so many others, and approximately 706 medical colleges, around 764 district hospitals. On the right side, you can see how many AIMS have been developed in the India, and around more than 40,000 private hospitals catering the need of India. I'm going to talk about a disease where still we all are like the blind man searching in an elephant, and India as a whole, or I would dare to say globe as a whole, might have the same scenario, and we don't need to discriminate between the rural and urban, because in this disease probably the face of urban area is in the same way. So diabetic food services in India, exactly the national count of dedicated diabetic food departments in Indian medical colleges is readily not available, and it might be a situation of many advanced and other countries as well. We need to have data, except the Tamil Nadu has taken an initiative where established podiatric clinics in multiple places to give the basic training of diabetic food. So India as a global capital of diabetes, 75 million diabetics with 150 million fit to be catered, increasing number of diabetic foot attacks, and every passing 3 to 4 minutes, one limb is being amputated. In this scenario, what challenges, which are already growing exponentially, are we facing, and are we ready to cope up with the infra and trained manpower? So case one, you can see a bilateral mid-age diabetic. On the right side, there are the just a couple of abrasions seen on the IP joint, and the left side, typical third metatarsal head discharging wound. Vascularity is good. X-rays are in the center, while the magnified views of each case are on the left and right side. You can appreciate the excessive dorsiflexion at the metatarso-pharyngeal joint, and here deformed third metatarsal head, probably an osteomyelitic scenario. The treatment option which was offered on the right side is Kellar's arthroplasty for the right limited joint mobility, dorsal rotation osteotomy with the K-wire fixation for metatarsus primus equinus, as well as the EHL lengthening was done. Flexor tenotomy done for the second ray, and this is a picture just after 4 weeks, and the bony union is occurring with a good gap Kellar's arthroplasty. On the left side, you can appreciate on the dorsum, there was additionally an abscess. So surgical approach given was EHL lengthening, first metatarsal head, dorsal, I will explain it. First, we'll go to the second, third, fourth, and fifth metatarsal head resections were done, debridement of the wound done. Only when the third metatarsal head was involved, the other areas were resected, because there would have been a transfer ulcer. And after you resect all four metatarsals, there is a high possibility of transfer ulcer to the fifth metatarsal or the first metatarsal head. So in one go, we have tried to find the solution, and this is the result at the end of the 6 weeks. So the take-home message is understand and treat the altered biomechanics of diabetic foot, offer the wholesome treatment, try to prevent the first ulcer, prophylactic surgeries in high-risk diabetic foot to be considered. And if we see the patient with the first ulcer, at least plan to avoid the second ulcer. The second case, a 75 years old man with this kind of infections, necrosis, blackening in the multiple areas of the foot. X-rays were non-conclusive with the aggressive sharp debridement. Tendo achilis was lost, ankle joint was open on all the sides, all the ligamentous supports and tendinous supports were lost. So in a view of whether there is a viability of the limb at the end of debridement, I just decided to put one minimum stabilization, and Klebsiella was grown, and this is how we ended at the end of surgery. On the fifth post-operative day, the blackening began. Then it's followed by exposed black calcaneum, fibula. At this level, we started the local oxygen therapy and factor X, which is my research topic. I will disclose after my publications are done. The gross slough and pus is coming out. Tendo Achilles is already gone. It's 21st day. Is it time to think about the amputation? Day 30, pus pouring from the ankle joint. Should we take a fast decision of amputation? And still we were not amputing because metabolically patient was stable and there was no proximal progress of the disease. I call this stage as the trench war of the First World War, where the bullets are not fired from either side and you just wait and watch for what is the opponent doing. So at the POD 40, the same protocol is going on and little ray of hope was seen. And at day 50, the wound became reasonably granulated. The foul smelling pus was stopped. And here we decided to now go for the more aggressive treatment. We stabilized the ankle, put the multiple K wires, ankle was open, debrided, all cartilages removed. And on day 60, we grafted, day 65 graft being accepted, 117 days, everything is healed with the implant removal, and we removed the wires and the foot was saved and the person was able to walk. In 2010, this I had developed for a failed angioplastic grade 2 amputation when everything was blackening in a diabetic and ANA positive multiple connective disorder. A simple oxygen chamber and it had given a result. Now we have got all these branded instruments with multiple modifications and the hyperbaric oxygens as well. But though these things are not available, so the take-home message is patience is the key. Advanced wound care, topping the basic pastry of good perfusion, infection control, stability in the ankle, metabolic management, standard wound care and passion to save the limb, keeping the economic aspects aside, is going to make the perfect cake for rebirth of the limb. Most of the answers for the diabetic foot challenges are not given in any textbook, so find your own cost-effective solutions. A 47-year-old man, type 2 diabetes, gradual onset deformity in both feet since 1 year, and landed up with there is no was gross rememberable trauma, acute swollen hot foot, anything, but developed the wound on the medial side of the right foot with the intermittent serosanguinous discharge. This was the clinical presentation. This was the X-ray, a classical midfoot Charcot with probe to bone test positive, suggestive of the osteomyelitis, which was again proven in the histology also afterwards. So left is the disease, right is the target. So planning was done on paper. 12-degree varus is to be achieved. In fact, my patient had 20 degree of the valgus, so total 32 degree of varus correction was planned on the paper. The osteotomy was designed, cut on the paper, did on the paper, and it was followed by surgery, tendo Achilles lengthening to restore the calcaneal pitch. And the things were done is the second ray was almost fused, so it was difficult to mobilize. The beaming principle was used with the modifications. The antibiotic coated stimulant was put on the medial cell with the chip of the bone grafts. Lateral side was open, a strut graft was kept, and additional stability was given with the external fixator. This is the restoration of the arch, post-operative views. The strict 6 months of non-weight bearing and posterior slab continued for 6 months. This is how the things progressed, went into a solid fusions, but this is not sufficient because this was a two-stage procedure was planned, and definitive fixation with multiple beamings, intramedullary and extramedullary, were following here. And also we did some peroneus brevis shortening to reduce the instability. And at the same time frame, patient was having the left-sided Charcot, but you can see at 6 months differences, there was no progress. So we decided to conserve. At the 9 months, we found one bony bump in the midfoot. So that was removed. And after that, this is how patient was able to walk. This is a 2 years follow-up picture. Patient is doing very well. Almost 100 kg, 6 feet height man, and this is his achievements. So one more patient with 18 months non-healing wound. Talus is completely coming on the ground, just fixed with the basic principles of talectomy and fusion with just K-wires and the bone grafting. 8 years follow-up, absolutely well-doing limb. So sometimes the old and economic ways will work. Every time you don't need very advanced weapons to fight with this. The same patient after 8 years, opposite side of the limb, where we did the principles of super constructs, and this is also doing well. So we are in the plethora of the implants, and always there is a discussion about whether it is a beamers, whether you are the rafters, whether you are the external fixators, whether you are the nailing, whether you are the super constructs. But using the all equipments properly and putting this triangle of stability in the diabetic foot Charcot is very important. So whenever we ask, there is nothing like a best car. Car should be chosen as per the road conditions. Only thing, driver has to be competent to drive any of them. So in one line, the challenges are both in the rural as well as urban areas. So dedicated diabetic foot training programs and centers are needed. Basic triad of biomechanics, perfusion and infection control is to be understood and well executed. Orthotic surgical offloading backup, the basic and advanced wound care, topical oxygens, hyperbarics, lasers, customization of all the costly treatment options to economic and local options by obviously not violating the basic principles. Focused research is needed in the Charcots. Focused research on the vascularly compromised limb, especially failed vascular surgeries and non-affording classes. And is TTT would be the fusion where the distraction tibial angiogenesis can be one of the options for where the angioplasties and bypasses are not possible. So to conclude, in every country, in every society, there will going to be the different villains, and at the same time, the different heroes will be there to tackle with them. So you have to choose your local hero to tackle your local problem. And if we do this, there won't be a much difference between the urban and rural face of diabetic foot. Let us work together to prevent the amputations. The target should be the ZAP, that is the zero amputation rates. Thank you very much.
Thank you, Dr. Amit. That was a very nice presentation. Now we move towards Dr. Dhrumin. Dr. Dhrumin works in Mumbai and he specializes in arthroscopy and minimally invasive surgeries in foot and ankle. He also has a lot of work in diabetic foot and foot and ankle reconstruction and knee surgeries. So over to you, Dr. Dhrumin.
Yeah, can you hear me?
Yes.
Okay. And can you see my slide?
No, we can see
My email.
Yes.
Okay. Let me try again. Sorry. And how about now?
Yes, you can. We can see now.
You can see my slide, yeah?
Yes.
Thank you. So, yeah, thank you everyone for including me in this one, Dr. Selene Parekh, for conducting this global town hall, which truly puts all the foot and ankle surgeons across the world at one place. And it's a great platform to encourage and discuss ideas and innovations. So my topic for today is inclusive communication with patients during pre and post-operative care. So slightly different from what Dr. Girish and Dr. Amit spoke about. And essentially, we are turning into a society who is now much smarter, and they are all Google prone, so they all research and come, and we need to communicate what we are doing with our patients. So why is communication important? Communication gives us clarity. So what is going to happen? It gives confidence to the patient and the treating doctor. It gives the courage to deal with the pain of surgery. And ultimately, that leads to success, which is improved outcomes of surgery. So whenever a patient comes to us for surgery, it's like giving a part of theirs to us to get it corrected, to get it rectified. So that is utmost important, that the patient should have trust in their doctor. And it is only through communication, not only that, through inclusive communication, that we can gain that trust and hence improve the quality and life of the patient. So before any operation, what is the state of the mind of a patient? So this is it. It is all confused because they are layman people. They have not done their medical graduation. They don't know the medical jargons. They don't know what is going on in the body. Of course, people do research and they do Google, but that is only half-hearted knowledge which they gain. And there are a lot of myths which they have about their problem and what surgery they are going to have. So before any operation, a patient has a lot of confusion about the whole process, and it's our duty to solve that. And that again is varied with the different personalities of the patient. Some people are very open, some people are extroverts, some people do find agreeable, some are neurotic, and henceforth. So surgery is a stress. So in coming to a hospital is a stress for many people, but admitting and coming to an operating room is a bigger stress for many patients, and their anxiety level can vary depending on their personalities. And of course, the post-operative outcomes will depend on their pre-operative anxiety level and the counseling which is done. And that has been proven in multiple studies that we have to counsel them. We need to tell them what is going on. Only then they will have improved post-op outcomes. So that is the key thing for us. Improved post-op outcomes means they will be happy, and hence we will also be happy. So what is inclusive communication? Inclusive communication means ensuring all patients, regardless of their background or abilities, they feel heard, understood, and empowered during their surgical journey. So that is the key message which this slide gives, and of the whole talk, that you have to have inclusive communication with patients, no matter what their understanding ability, no matter what their language barrier, they should understand what is going to them. So how I do it, I'll just share my experience with a case example. So this is how a patient comes to us, or any foot and ankle surgeons, all of you all. So any patient, just this is an example. So this patient came with a fracture she had 4 months back, and she came to me after 4 months. And this was her X-ray, that was her deformity, and she was walking on this. So let's see if this video plays. Okay, so the video is not playing, but yeah, she was walking with this grotesque deformity. And with this, when the patient walks in, you should have a basic understanding that what are the educational levels of the patient, what is the family background of the patient, who stays with them, how much care they give to their body, or have taken medical care and advice. So that information we get from the patient's behavior, from the way they talk and the way they present. So we have to explain them and what is the problem first. Do they need a surgery, or they can manage without a surgery? Because always any surgery is a form of surgical insult. We should try and avoid it as much as possible. Even though if we are foot and ankle surgeons, there are so many conditions in foot and ankle itself which can be treated non-operatively, and we should embark on those first. And when only we think that yes, I will be able to improve the life of a patient with my surgery, then we should suggest them. So in this case, patient had pain, patient had deformity. This was a Charcot deformity. So the pain was not from the fracture itself, it was from the deformity and the abnormal biomechanics. So the pain was upwards in the knee, in the hips, in the spine. And of course, she had diabetic neuropathy. So no fracture pain as such, and no pain in the foot and ankle as such. So what is the patient's expectation from surgery? In this case, I had to ask her, what do you want from this surgery? So she says, I want to walk with a straight leg so that I can walk longer. With this deformity, I'm not able to walk longer, and she gets tired easily with pain happening in all other joints. Being a diabetic, it is very important that we medically optimize them. So in this patient, diabetes, hypertension, thyroid, which she had, and HbA1c, we need to make sure that is under control before embarking on the surgery. And of course, the fitness for surgery. So it's not a one-man show. We have to include the diabetologists, her physician, and all the nursing care physiotherapists for this surgical process. So once this all is done, this is in the first consultation, which has been explained to all the patient, and of course these points. So this all happens in the OPD. So explain the surgical journey in their native local language. So that is how we should communicate, and inclusive communication. What the surgery involves. So we have to explain them that we are correcting the deformity, we'll make the leg straight. Now that involves that this is a major surgery. She has to be hospitalized. So we need to give them hospitalization details of 2 days or 3 days or whatever. what will the post-operative care be? How much pain will she have after the surgery? She need to manage her sugars after the surgery. What will be the rehab and physiotherapy after that? And then ultimately getting back to normal life. And in the OPD, we have to give them important contact numbers, whom to contact to in case of emergency, whom to contact for booking the surgery. So all these minute small points that alleviates the patient's stress and the family stress. So once the patient decides, so this particular patient, once she decided, she came with both her sons. Once they decided, they were happy that they are going in for a surgery to get their legs straight, to improve their biomechanics. We need to prepare for the day of surgery. So as a surgeon, our job does not end there. We have to be there from beginning right till the end. So RMO advice. RMOs in our country, we call them resident medical officers. They see the patients whenever the patient is admitted to the hospital, and they give their pre-operative advice. So they contact us, we give them advice what to be done, what not to be done. We have a pre-anesthetic checkup. So the day before surgery, patient is admitted, the anesthetist sees the patient. They are very important part in the whole surgical process. They will explain the patient how the anesthesia will go on, what will be the post-operative pain level. The nursing care, the nurses who are there in the hospital, they explain the patients as well. And finally, before the surgery, it is very important that you yourself personally meet the patient and clear any final doubts before the operation. So nowadays, operation is not just about mutual understanding. We are a lot at a medical legal level, not only in the States and UK, even in India, it is increasing. And medical legally, we have to be sound, correct. We need to make sure the consent marking is done and all the risks and benefits of the surgery are explained to the patient. So this all is a part of inclusive communication. We need to explain them what are they going through. Even the smallest risks like numbness in the scar, small risk of infection, small risk of non-union, if we are fusing any joints, the risk of adjacent joint arthritis, if we are doing any ankle replacement, the longevity of the ankle replacement, just the example. So we need to explain them that all goes in the consent process. And finally, once the surgical process is done, we need to make sure that the patient is well comforted in the operating room. And once she comes back in the ward, we post-op care. So what will be the plaster care? We make sure we see the patient post-op on day one, and finally at their discharge. So how will the patient be mobilized, walker or crutches, how will they need it? And we include the physiotherapists in them, because the physios have their own different way. As surgeons, we are busy, we will give just few lines of advice and go away. But the physios, they will stay with them for an hour. So that truly makes a change of perception in the patient and improves their quality of life and makes them clearer and better understanding to them. Pain management, how will the medicines needs to be taken at home? And finally, home care. Once you go home, how to take care of the plaster, not to make it wet. All those have to be explained to them in conjunction with yourself, the nurses, the physios, and the ward doctors. So this was finally the patient who had this deformity correction. She had a tibiotalo-calcaneal nail. So this was a Charcot ankle fracture with a Charcot ankle. So we had to do a deformity correction with a supramalleolar osteotomy and a TTC nail, and that was the final outcome. So this is what the patients expect at 3 and 4 months, to walk in the sandals. So this video is not playing, but she's walking in the sandals. So we have to make sure that they understand that this is not possible all the time. So I had clearly explained to her before the surgery that you will have plaster non-weight bearing for 2 months. You will be in a walker boot, big walker boot for 2 months. Only at 4 months I will let you walk, only if your wounds are all healed and your pain is gone and the x-ray is showing good signs of union. So finally she reached that stage, but this all has to be explained before. By chance, if suppose I had not explained her and she would have expected that at 6 weeks I have to walk in my sandals, then it's not a good outcome. Patients are not happy, and ultimately it's not a good outcome for the surgery. So what are the key elements of inclusive communication? I'll go quickly through this. Plain language, explain in the patient's best words what they understand, avoid medical jargon. Diverse communication methods, give them some visual aids, show them previous patients' videos, and show them any written materials which you have, and call in interpreters if needed. Respectful and empathetic language. You need to talk to elders like the elder, you need to talk to children like children, and you have to change your way of talking as per the patient and be respectful. Patient-centered approach. Always patient preferences first, values and needs in communication. Active listening and encouragements. Always ask the patient to ask questions, whatever, clear their doubts right there before we go in for any surgery. We need to be culturally sensitive. Consideration of disabilities, like for a patient who is older, we cannot expect them to run or do a marathon. We have to be considerate of their disabilities and give them that level of life. We need to involve the family. Most important in Indian scenario, where people live in a close-knit family, they have large family groups who all come in during the surgery day. Everyone has to be explained, so it is important to involve them when appropriate. That gives them a good moral boost and confidence. Everything has to be documented, as I explained, medico-legally. We have to be sound and safe. Everything has to be documented. And continual improvement. We have to reflect on our own communication methods. Are we going wrong somewhere? Do we need to improve our own communication methods and do that? And finally, so what are the benefits of inclusive communication? Number one, improved patient understanding. The patients, they know what is going to happen to them, what will be the outcomes. Enhanced patient satisfaction, better health outcomes. We reduce the risk of errors. Once everybody knows what is going on, the family members, the nurses, the physios, the ward staff, we ultimately reduce the risk of errors and increased patient empowerment. So that's all about my talk. Thank you very much. Thank you.
Thank you, Dr. Dhrumin. We move on to our next talk by Dr. Satish. He works in Chennai and he specializes in orthobiologics and knee preservation, and ankle preservation. He has more than 10 publications in various journals. So, welcome, Dr. Satish. You can go ahead with your presentation.
Yeah. Thank you, Dr. Madhura Kulkarni, for those kind words. And is my screen visible?
Yes.
Yeah. The topic for my presentation is on orthopedic innovation and their impact on minority population in foot and ankle surgery. And so the primary aim and objective of my presentation is to share with the global population the unique and innovative plating system which we have developed for the distal tibia, which can be applied through the posterior aspect. And this system allows constant upgradation and easy alterations, unlike other systems where once it is out, it cannot be changed or it cannot anything, no alterations can be made. This system allows that process, and the use of new technology and methodology in assessing the functional outcome rather than the range of movements and the fracture union. So this is the crux of my whole presentation for the next 10 minutes. And of course, my entire study has been approved by our institutional ethical committee, which is one of its kind, which is approved for clinical trials in South India. And this distal tibia fractures, to be very precise, there are actually they are a soft tissue component with a fracture, where major emphasis is on the soft tissue injury, and they contribute to about 1 to 10% of the lower limb fractures. And there are n number of methods available for treatment: the nailing system, the plating system, the external fixators, and we narrow down our focus to the plating system. So when it comes to the distal tibia, there are two plating systems which are involved. One is the anterolateral system, and the other one, which is more commonly used, is the medial plating system. And of course, this article throws light onto the importance of the blood supply when the plating system is being applied to the distal tibia, and how stripping the bone of the periosteum can cause devitalization and avascular necrosis. And pictures like this aren't very uncommon in our practice. This was an anterolateral approach which was done in another unit in our institution. And here you can see the exposed medial implant. So how we can overcome this soft tissue compromise with the plating system? You need to take advantage of the flat surface of the posterior aspect of the tibia, the good vascular bed of the posterior aspect when compared to that of the anterior aspect, and the good coverage which is being provided by the FHL when the implant is applied on the posterior plate. So when we think about all these concepts, we have a solution on how all these problems can be overcome. And this article throws light on how the bulk of FHL acts as a buffer. And hence, this factor has to be considered whenever we design a posterior distal tibia plating system. And hence, when we look into literature, there will be n number of attempts. This is a small cadaveric study where they have used the contralateral anterolateral plate, which has been applied in prone position for the posterior aspect. And this is another article where the 90-degree cannulated blade plate has been used for metaphyseal non-unions. But the problem with this system was it couldn't be used whenever there is an extension into the joint or comminuted fractures. And I was surprised to notice that from our own institution, they have tried this posterior plating system. And what they have done is they have bent the DCP, the dynamic compression plate, and they have applied it on the posterior surface. But the sample size was very low, and they did not have adequate follow. And a word about this very, very useful approach, the posterolateral approach, which was first proposed by Chastang in 1924, and it was popularized in 1940 by Harmon. But the fear of injury to the neurovascular structure prevents surgeons from using this approach. Once we are familiar with the anatomy, we can definitely use this very, very useful approach for the posterior plating system. And this article, when we started in 2019-20, there was no anatomical plate for the posterior surface of the distal tibia in the market at that time. So we thought, why can't we go ahead and do something about that? And that time when we started this process, only the posterior malleolar plating system was available in the market. And those import in India, there was no system available. And only the imported plating systems were available, and the price of this were rocket high. Not only that, they did not suit the innate anatomy of the South Indian population. So that was our second consideration, why there was a need for this plating system. The actual plates which were in vogue at that time for fixing this distal tibia plating fractures were the distal radius system, which was a 3.5 system. And the problem with this was the strength wasn't sufficient and the length of the screws were insufficient while we used it to fix the distal tibia through the posterior aspect. And the other plate which we used was the proximal tibia buttress plating system, which we reversed and used. But the problem was the plate was much bigger than the bone itself, and it causes irritation of the muscle. So what is that we needed? We needed an actual system which has the agility of the 3.5 system and the strength of the 4.5 system, a combi system. So that was how we got the idea. Why can't we have a system which has a combination of both these systems? And this article, it really threw light on how we have to go about with the plate designing step by step. And it was very, very useful for us. So what are the parameters we took into consideration? We took two parameters. One was the posterior tibial slope angle, and the other was the mediolateral width of the distal tibia. And we took the CT of 50 males and 50 females, 50 right side and 50 left side. And we took an average of all these. And we took help from our statistics department, and we came out with the final indices of all these. we also got other parameters like the twisting angle, which was helpful in when we decided to go over with the length of the plates. And with a little help from the National Hub for Healthcare Development, Instrumentation Development, which is there here in Chennai, we came out with the shape which we wanted, and the Mimic software is very precise. When we feed all these data, the images and data in the Mimic software, they exactly comes out with all the dimensions and the final anatomy. And when this output is being fed to the flash fogger, we get a very, very precise printed material, which is very precise up to 11 microns. And the final output, we have the prototype in polylactic acid, which is also a biocompatible material, which looks something very similar to this. And when this is being given to a local vendor who is an approved vendor for the plate production, we got the preliminary first generation design, which was a combi system or the 4.5 system, oblong holes, and the 3.5 system for the distal fragment.
Dr. Satish,
Yes.
sorry to disturb you, but you just have 1 more minute to finish the presentation.
Okay, ma'am. So we did a radiological comparison. We also did a cadaveric superimposition technique, and we compared all these things. And here are some of the results. Here you can see the first case was the distal radius one. The second case was that of the proximal tibia, and the third case was that of the newly designed plating system. And the results were comparable. And this was the analysis which we done. So we used the wireless. We got these wireless small sensors which were tied on to the patient. And instead of having a gate platform, we documented just walking 10 meters and climbing up and down the stairs. And this is the actual recording which was done in our OPD. And then after that, these parameters were captured. And this was actually the software which was developed for the defense system of India. And then all this analysis was given in a chart. And here we can clearly see what is the difference between the affected and unaffected side. And the strength, for the strength testing, instead of doing the conventional way, which is normally being done with the structural design department, we did that anybody software where we made the patient to jump and then stand in a single stance and then see how it is. And our plate passed through in all the tests. And this is the intellectual property rights, and ours is in the final examination stage. And we have come out with the third generation where we feed in the patient data and we receive a custom plate designing. So to conclude, I would say our plating system is unique and has all the anthropometry inputs and has the modern technology inbuilt in it to name it as a new avatar in the management of the distal tibia fracture management, which is applied to the posterior aspect. Thank you everyone for your patient listening. And these are my contacts. Do feel free to contact me for any doubts. Thank you very much.
Thank you, Dr. Satish. It is a lovely innovation that you have done. Coming to the last talk, we have Dr. Sree Ganesh, who works in Kochi in Kerala, and he also specializes in foot and ankle trauma and joint replacement. Over to you, Dr. Sree Ganesh.
Hi, Madhura. Is my screen visible?
Yes.
Yeah. Thank you, Madhura, for that wonderful welcome. My dear fellow orthopedic surgeons and healthcare providers around the globe, it is warm greetings from India. First and foremost, let me express my heartfelt gratitude to Dr. Selene Parekh and the organizing team for conducting such an event in a global scale. And I believe it's a privilege to be in this platform, and I have selected this particular topic, which I found very exciting: improving patient outcome through a culturally sensitive care. Even though at first I thought that this title is some sort of a simple or some sort of a nice talk, but when I thought that we don't actually give it a thought during our normal day-to-day clinical practice. Because most of the times as an orthopedic surgeon, we take an authoritative stance And we assume that the patient will follow or must follow whatever advice we give them, because we bombard them with our clinical jargons, we bombard them with our clinical knowledge. But by doing so, we are actually making a mistake. The patient is actually an identity which is backed by his beliefs, social, cultural, emotional, regional, religional preferences. He's not just a machine with blood and bones. So, like what Dr. Dhrumin Sangoi has told in his talk, that the communication has to be done properly, that only when we are able to communicate, we are able to connect with those patients in a language which the patient can understand, we can affect his mental, social well-being, or the patient will start listening to us. Only then the patient will follow our treatment and make our treatment a successful one. So let us take that particular perspective into how we can improve in our foot and ankle practice. I know that the foot and ankle, there is a global audience of foot and ankle surgeons in this platform. So whatever I'm going to tell may not be applicable to all of you, but let us discuss some suggestions and tips. Okay. So first of all, let us have a look on this footwear pattern. We know that the footwear, for some, it is a simple accessory. For some people, it will be a fashion statement. And for us orthopedic surgeons, it is, excuse me, ma'am?
Are you playing a presentation?
Yeah.
No, we can't see it.
No. Okay. So is this visible right now?
Nope.
Okay. Just okay. So is this visible right now?
Better.
Yeah. Okay. Is this visible?
Yes.
Yeah. So let us start with the footwear pattern. As I already told you, the footwear can be a different meaning for different people. It can be either a simple accessory or a fashion statement. But for us orthopedic surgeons, this is actually a tool to correct the deformity, to rehabilitate the deformity. But in certain religions, the footwear also has a deeper cultural as well as spiritual meaning. I would like to take an example of what is a foot binding practice now. It is a classical example of how a custom or a tradition can deform a normally growing foot, and that is being considered high standards in that particular community. So now let us have an Indian experience. I am from India, and India is a cultural diverse land. In India, everywhere there is cultural differences, and actually that is our way of life. Wherever we look, there will be a lot of traditions, rituals, customs, etc. And I'm sure some of you might have come to visit India as a tourist. In India, every nook and corner, every place, there will be a place of religious worship. Either it is a temple or a mosque or a church or anything. And we Indians, we usually consider these religious places as sacred, as a place of respect. So we usually keep our footwear outside as a mark of respect. But the problem with that one is the temples are usually a potential site for injury. I would like to share a case given to me by my fellow speaker, Dr. Amit Burande, that this is a case of an example of a burn that happened after walking barefoot inside a temple. Because in the Indian scenario, the temples will have a lot of burning items like burning camphors, incense sticks, burning candles, etc. So, certain key clinical considerations and suggestions which we can give to such patients, especially to vulnerable patients like diabetic patients, is that we can avoid advising complete avoidance of barefoot walking. Instead, we can give them temporary modifications like clean socks with a grip sole. These are called as temple socks. Similarly, after the pre and post worship foot care, we can advise them to have a moisturizing dry skin, checking for cuts if diabetes, etc. Another consideration is that certain prayer postures are very important, like in Islam, Hinduism, like yoga, etc. In such conditions, our treatment aim should be focusing on the flexibility and the strength exercises. And similarly, for people who has to wash multiple times a day, we have to do waterproof bandages or physician-approved technique to avoid aggravating the wound. And there are also certain dangerous religious treks in India, like Shabrimala. So again, we would like to advise our patient a preemptive advice on strengthening foot muscles, managing blisters, and maintaining a hygiene to prevent infections. So in India, the significance of a healthy and a beautiful feet is beyond the catwalk fashion. Because in some regions, in arranged marriages especially, there is the bride's appearance, the prospective bride's appearance will be carefully scrutinized from the head to the toe. So it is not uncommon for the parents to come with their young teenage children to get their deformity corrected, especially like the hallux valgus deformity being corrected. And the aim is not to get corrected for functional reasons, but for cosmetic reasons to get a good match in the market of arranged marriages. So in India, any foot deformity, whether it's a rheumatoid or a Charcot or a leprosy, they want to be hidden because they are often seen as a cultural taboo. These deformities may be associated with a stigma, and we like to understand that this social context is crucial and we like to treat and correct accordingly. Another case example is a particular example how the customs, how practicing customs in India can also be troublesome. We all know that in India, especially in Hindu families, the second toe ring is a customary item for a wife. And after prolonged use of this toe ring, sometimes this can lead to a complication. And then in this particular case, there is a second toe gangrene following use of meeting. And I would also, yes, yes.
Sorry, but you have to wrap up in a minute.
Oh, it's just hardly a minute. I need 2 minutes. Okay. So another innovation is the Jaipur foot, which shows that there's a cost-effective method which allows the patient to flexible, walk barefoot, squat, etc. So some clinically useful tips and suggestions. There are a lot of housewives who walk in their homes with barefoot. So the problem with that one is that they don't have any protective wears and they do seldom exercises. So house slippers we can advise them. Also we can use night splints. Similarly, in the laborers, we all have heard about eumycetoma or Madhura foot. And in India, especially the laborers and the fishermen work in a very moist, damp environment with a barefoot. We like to advise them accordingly. Similarly, for the ankle foot orthosis, as I already mentioned, the people want to hide their deformity. So we like to use some low profile AFO like carbon fiber, and we like to allow side entry shoes so as to accommodate these AFO discretely. Similarly, we can advise removable soft silicone PU supports. In diabetic foot washing, which I already mentioned, and almost all these diabetic patients will be walking barefoot in their indoors. We may be able to advise removable insoles, MCR, other similar protective devices. This is a slide from CDC. And surgery and post-op considerations, the post-op immobilization, especially after ankle fusion or osteotomy, plaster or boot use may interfere with sitting cross-legged. In such patients, we can use temporary exemptions or provide removable boots. And we can often advise them reclining sitting adaptations. Similarly, in female, they used to go to open footwear like kolhapuri or sandals. So we like to use post-op orthotics to fit into flat, not elevated open footwear. So in short, orthopedics is not just realigning bones and fixing tendons. We like to understand the patient as a whole is a basic step. History taking, it has to start with the history taking, as Dhrumin has already told about history taking, and we like to treat the patient. Ask yourself, what does the patient truly want? And we like to also think in the rehabilitation phase, what extra small piece of advice we can offer them to get back to the normalcy. So thank you for the patient listening. Thank you, Madhura.
Thank you, Dr. Sree Ganesh. That was a wonderful talk. And we are running short of time, so there's no time for questions, but over to Dr. Alan Yan.
Yeah, thanks for the great talks, great works your groups have presented. And apologize for the limitation of times. We do not have time for any questions. And we're going to move on to the next session. And again, really appreciate your nice words. And we're going to move on to the next session.